Hi there, my name is Kyle Morrison. I'm a student with the FNP program with Valdosta State University. This is my wife, Carly. She's going to be my patient for a basic cardiac and thoracic assessment. And do you give consent for this video?
Yes, I give consent.
Okay, so let's begin. First, inspection. We're going to inspect the trachea. We're going to make sure that it's symmetrical, midline, no obvious signs of trauma or deformities, which there is not. We're also going to inspect the jugular venous pressure, which for that you have the patient go ahead and recline at 30 to 40 degrees. And you ask the patient to turn away from you. Good. And you look for the impulse from the jugular pressure, which is not palpable, so that's usually a good indicator that you found it. So you just take an object that's straight, go from that portion that you can see pulsating, and then measure just below the manubrium. So in Carly's case, here you go. In Carly's case, she's actually at 1 centimeters. And 1 centimeter is kind of on the lower spectrum of normal. Normal range for JVP is between 2 to 3. However, some measurements include they'll add 5 centimeters to account for the distance it takes to get to the aorta. So in that aspect, it would be between 7 and 8 is your norm. If you're less than normal, you're looking at dehydration, maybe malnutrition. If it's elevated, you're looking at fluid overload, such as seen in congestive heart failure. So that takes care of the inspection. You can also just look at them overall and just see if they're using any kind of accessory muscle use, if they're having any difficulty breathing, which in Carly's case she is not. And we'll get to it later, but for a good assessment of how they're breathing, we can look at posterior respiratory expansion. So now we're going to stick with the neck, and we're going to do a little bit of palpation. So I like to start off with the carotid arteries. So we'll just feel here. So it's +2. +2 equals symmetrically, regular rate and rhythm. We're also going to palpate the lymph nodes. Now, the lymph nodes, we have the submental, we have the submaxillary or submandibular, we have the parotid lymph nodes or the tonsillar lymph nodes, we have the superficial cervical chain, the deep cervical chain, the occipital, and I think that's all of them. And then, so start with the submental. There's nothing palpable there. Oh, sorry, the clavicular, that was the other one. So submental, then bilateral, submaxillary, then bilateral parotids, nothing palpable, which is normal. The preauricular, forgot that one. Postauricular, occipital, okay. Superficial cervical chain, nothing palpable. Deep cervical chain, nothing palpable. And then clavicular, nothing palpable. So related to the lymph nodes, we're also going to assess palpate the thyroid. And at Valdosta State, we're taught to do a posterior approach, but there is an anterior approach as well. So posteriorly, we're going to see for or feel for the cricoid cartilage. Then we're going to go 2 rings down of the trachea, and right there should be the isthmus of the thyroid. And then on both sides are the nodules of the thyroid. So ask the patient to swallow. Okay, you should feel a slight rise on one side, and then for the other side, swallow. Okay, and then just a slight rise on the other side, but they should be equal bilaterally. Should be hardly palpable. And then lastly, while we're here at the neck, we're going to assess cranial nerve 11. So for cranial nerve 11, we're going to assess shoulder strength. Shrug, good. So that's +5, best strength you can. 0 would be paralysis. And then we're going to do the head, the neck still. Good, 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 good. Other side, good, good, good. Okay, so cranial nerve 11 is well intact. Now, we're going to move down to palpation of the thoracic cavity, or thoracic chest here. We're going to do tactile fremitus using the ulnar aspect of your hand and the ball of your hand, because that's the most vibratory sensitive portion. So I just tell the patient to say 99. 99. And you'll feel that slight vibration. 99. Good. Again. 99. Good. Again. 99. Good. 99. Good. 99. Good. Okay, and then we're going to percuss now. So we're going to listen for resonance, a normal finding for air in the lungs, and we don't want to hear dullness, that we might have a pneumothorax going on, and we don't want to listen to any kind of flat percussion sounds, because that'd be indicative of no air in the chest cavity, so that wouldn't be good. So we'll go ahead. That's definitely resonant. Resonant. We'll compare bilaterally. Good. Good. Now it's interesting because on the right side you actually have the liver, so you can have a little bit of a different sound, but you can keep palpating, and that's an assessment for a different time, but is the liver span. And for the right side, it's the same thing, except what you're looking for is not only the resonance of the lung, but you also have a gastric bubble that sits on the left side, so that can also produce a very resonant sound. Lastly, we're going to auscultate the anterior here. So we're going to auscultate for lung sounds first. We have the bronchial breath sounds, kind of short, high-pitched. And then we have the bronchiovesicular as it goes into the bronchioles here. And then we have the vesicular as it expands into the rest of the lobes of the lungs. Now, the anterior aspect of the thorax, between intercostal space 2 and 3 is where you'll hear the bronchial sounds, and then posteriorly it's between 2 and 4. So just as percussion in tactile fremitus, we go in a symmetrical pattern and assess bilaterally. And make sure you breathe through your mouth to eliminate any kind of adventitious sounds. Ah, gotcha. Okay, let's see. So breathe. Good. 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 Make sure you go skin to skin to assure there's no kind of, again, sounds that could mimic adventitious sounds like crackles. Good. Good. Okay. So that takes care of the lung sounds. And you want to pause the... Okay. So now we have the cardiac sounds. We have the aortic area. That's the second intercostal space. Right sternal border. Then directly across, you have the pulmonic area. That's second intercostal space, left sternal border. Then you have third intercostal space, left sternal border, Erb's point. Then you have the tricuspid area. That's going to be the fourth intercostal space, left sternal border. And then lastly, you have the mitral or apical aspect, which is going to be left midclavicular line at the fifth intercostal space. So we'll listen to each area with the bell and diaphragm. Diaphragm for the S1, S2, possibly S3, S4, and then we are also going to listen with the bell for any kind of murmur assessment. Okay, S1, S2 present. No evidence of murmurs. S1, S2. No murmurs present. Go down one more intercostal space to Erb's point. S1, S2. No murmurs. Tricuspid. No abnormalities. Then lastly, the mitral. Same. Okay, so that takes care of the anterior portion. Now, what we can do is a assessment of the point of maximum impulse, PMI, which you just feel for the portion of the thorax where you can feel impulse from the heart, particularly the left ventricle as it sits down here. And with Carly, I know that it actually sits midclavicularly at the fifth, sixth intercostal space. And if it was hard to assess, Carly luckily is kind of on the skinny side here, so she's easily assessed for that. But to help with that assessment, you can have the patient lay on their left side and be able to displace the left ventricle a little bit more to assess it better. And if it's displaced more axillary, you're looking at cardiomegaly or issues that would cause like left ventricular hypertrophy or like CHF. Okay, so lastly, we're going to assess the posterior aspect and then finish up with the pulses. So posteriorly, as I mentioned before, we have posterior respiratory expansion. You just take some skin and fold it like that, or pinch it together. And when the patient takes a deep breath, as hopefully the thorax expands, go ahead again. Your hands should symmetrically expand laterally about 2 to 3 centimeters. So that takes care of that. And then same as the front, we're going to percuss, but you have to go around the scapula, of course, listening for resonance. That's good. We're going to compare bilaterally. Okay, resonance noted bilaterally, all lobe fields. And then again, Carly, if you would, just make sure you breathe through your mouth. Sorry. Okay. Good. So that takes care of that. Now let's do some tactile fremitus. Say 99 for me. 99. Good. 99. Good. 99. Good. 99. Good. 99. 99. Good. Tactile fremitus is intact. Now lastly, let's work on the pulses. So if you would, Carly, turn around for me. We're going to compare symmetrically or bilaterally. Let's see. So we're feeling for the brachial pulse on the inner aspect of the upper arm here. And with Carly, it's a +1. That's typical. Even though as a grade that would be considered diminished, +2 would be considered normal. But that's typically what you find for brachial. And then radial, here on the radial aspect of the wrist, comparing both. It's +2 bilaterally. It's expected, regular rate and rhythm. Okay, and then we're going to check the rest here. So, go ahead and put both. So, we're going to check popliteal just behind the knee here. Okay, that's +1, +1, equal bilaterally. And then we're going to check the posterior tibial, which is on the inner aspect of the ankle here. There you go, and that's actually a +2. Usually you find +1, or I do anyway. +2, equal bilaterally. And then lastly, the dorsalis pedis. If you have trouble finding a reference point, ask the patient to flex the greater toe, and that ligament that pops out, you will see just lateral to that is usually where you can find that impulse. And that's +2 bilaterally. So we have good perfusion. And lastly, let's check capillary refill. Good, it's nice, brisk. Color returns under 3 seconds. Let's just check your fingers as well. Well, you've been sitting on this hand. And nice and brisk, less than 3 seconds. So that concludes a thoracic and cardiac assessment. Thank you.